Hi, I'm Dr. DJ Heusler, and welcome to the module on anterior uveitis in small animals. All right, so where are we headed in this module? We're going to look at anatomy of the eye, pathophysiology of uveitis, diagnosis, canine anterior uveitis, feline anterior uveitis, how to work these cases up, and therapy. The structure of the uvea is variably pigmented fibrovascular layer. It's highly vascular, which contributes to the nourishment and cooling of the eye. It's composed of fibrocytes and melanocytes. There's an anterior and a posterior portion of the uvea. The anterior portion is the iris and the ciliary body. The posterior portion is the choroid. The anterior and the posterior portion are both continuous with each other. There's a muscular layer to the uvea, which is the iris sphincter and the dilator. There's also a ciliary body muscle, which is an additional muscular layer of the uvea. The function of the uvea is that it provides nourishment to the eye. It is the main intraocular vascular supply. It brings oxygen to a highly metabolic retina. It produces aqueous humor, which is a clear ultrafiltrate. It regulates light via the pupillary aperture, and it assists in accommodation, being able to see depth within objects. Anterior uveitis is inflammation of the iris and the ciliary body. But this doesn't tell us a whole lot, so let's look at this deeper. Common clinical signs that we see with uveitis include blepharospasm and photophobia, conjunctival hyperemia, an episcleral injection, epiphora, meiosis because there's a prostaglandin release. We see aqueous flare. We see iritis or rubeosis iridis. We can see hyphema within the eye, corneal edema, corneal neovascularization. And when we see corneal neovascularization in cases of uveitis, these blood vessels will be deep stromal vessels. Deep stromal vessels indicate that something is going on inside the eye, whereas superficial corneal vessels indicates surface disease. We'll also see chorotic precipitates, and we can see intraocular pigment dispersion. Pathophysiology of uveitis includes that there is a tissue injury to the uveal tract. There becomes increased blood flow to the uvea. Inflammatory cell infiltrate increases to the uvea, such as lymphoplasmacytic, suppurative, and granulomatous reactions. There's vascular permeability, a breakdown of blood aqueous barrier, cytokine and prostaglandin release and activation, and then plasmoid and fibrinoid aqueous. There is cytokine and prostaglandin release and activation. There becomes plasmoid and fibrinoid aqueous. And lastly, a pre-iridal fibrovascular membrane or PIFM forms across the surface of the iris. Here are two pictures, histologic pictures, of a pre-iridal fibrovascular membrane that's forming across the surface of the iris. This membrane then will grow over the iridocorneal angle and leads to increased intraocular pressures, or glaucoma. Ocular sequelae of uveitis include synechia, anterior and posterior synechia, an iris bombée, which is where the iris adheres to the lens, and then aqueous pushes that iris forward. That's what this picture is here that's provided. Glaucoma can occur secondary to uveitis, which is secondary to a pre-iridal fibrovascular membrane, and peripheral anterior synechia occur. Cataract formation is common in cases of severe uveitis, and retinal detachments can occur as a consequence of uveitis. The number of causes of uveitis is intense, which can lead to a frustrating attempt to try to diagnose the cause of uveitis. There are non-infectious causes as well as infectious causes. Non-infectious causes include autoimmune, cataracts or lens-induced, ulcerative keratitis, scleritis, neoplasia, and trauma. Infectious causes include fungal causes, protozoal, viral, parasitic, algae, and bacterial. Here are two pictures which show uveitis in small animals. This first picture shows a lens-induced uveitis. This cataract came on very quickly and created increased inflammation on the inside of the eye, which is represented by rubeosis iridis, or the engorged blood vessels of the iris. This second picture was caused by blastomycosis, which created intense inflammation on the inside of the eye, resulting in hyphema, corneal edema, and fibrin within the anterior chamber. This next picture shows intense inflammation secondary to cataract formation and lens capsule rupture. There are large amounts of chorotic precipitates and fibrin within the anterior chamber, as well as posterior synechia. And the second picture shows a nice description of rubeosus iridis, or an iritis. This first picture shows another eye with intense uveitis with deep corneal blood vessels, conjunctival hyperemia. And the second picture shows intraocular cancer, most likely associated with lymphoma, causing inflammation within the eye. Diagnosing anterior uveitis is important. The classic eye with uveitis shows blepharospasm and photophobia, conjunctival hyperemia with episcleral injection, aqueous flare, miosis, mild corneal edema, rubeosus iridis, and hypotony compared to the contralateral eye. But not every uveitis patient presents classically. So what do I need to get a proper diagnosis? Don't skip the basics. Complete ophthalmic examination. Obtain a thorough history. Examine at an arm's length. Assess menace, dazzle responses, and pupillary light reflexes. Retroillumination of the eye, utilizing a strong pen light or transilluminator. Obtain intraocular pressures, perform fluorescein staining, and perform a Schirmer tear test. This is a photo of an eye with intense aqueous flare that can be seen in between the iris and the cornea. Aqueous flare is essentially pathognomonic for uveitis. So if you see this, the patient does have uveitis. So with aqueous flare, how do I detect it? Well, with a slit lamp biomicroscopy, there's a slit or focal beam setting which gives you a very fine beam to detect aqueous flare. And this is the gold standard for diagnosing anterior uveitis. However, with a direct ophthalmoscope, it's a small light. Most of them do have a slit beam, and you can take this at a tangential view and diagnose anterior uveitis or aqueous flare that way. However, with this case of anterior uveitis, this aqueous flare is very obvious. The most common overinterpretation is with intraocular pressures. If you take a patient's pressures and they're low with no other signs of uveitis, that does not necessarily mean that they have uveitis. They can also be high with a secondary glaucoma. With miosis, that's not always present. Sometimes there's a mydriatic pupil due to synechia. Sometimes there's a pharmacologic mydriasis, meaning that someone gave this patient atropine or tropicamide before you saw them and caused them a mydriatic pupil. There can be a secondary glaucoma, so the glaucoma is causing the pupil to be mydriatic. Or you could have Horner syndrome, where they do have miosis, but it is due to Horner syndrome and not due to uveitis. So don't forget a thorough physical examination, and this is important for testing. Other non-infectious causes include autoimmune, which is very common. Pigmentary uveitis is very common, which is this picture here that's provided. Pigmentary uveitis is very common in golden retrievers and results in deposition of pigment on the anterior lens capsule, which also results in cataract, loss of vision, and secondary glaucoma. Uveodermatologic syndrome is another non-infectious cause of uveitis. Cataracts, which were caused by diabetes, can cause lens-induced uveitis. Ulcerative keratitis can cause a secondary uveitis. Trauma to the eye, neoplasia to the eye, such as lymphoma, melanoma, or multiple myeloma, and then infectious causes such as fungal, which in this area would be blastomycosis. Neoplasia within the eye can also cause a secondary uveitis, neoplasia including lymphoma, melanoma, multiple myeloma, and other tumors that can occur within the eye. Infectious causes such as fungal, blastomycosis, aspergillosis, histoplasmosis, or coccidioidomycosis, rickettsial causes, and parasitic causes. Pigmentary uveitis, or what's also known as golden retriever uveitis, is highly underdiagnosed in this breed. You must dilate the pupil in order to see most of the lens capsule, which is how you make your diagnosis of the radial pigment on the lens capsule. If the patient has radial streaking on the lens capsule, this is typically indicative of this disease. Patients will have a very low-grade, non-painful uveitis, which can lead to cataracts. Cataracts will cause additional uveitis, and then this can lead to a secondary glaucoma. At minimum, these patients should be managed on topical flurbiprofen or diclofenac once to twice daily and rechecked every 4 months. Cataracts are one of the leading causes of uveitis in dogs. Diabetic cataracts progress very quickly, and this leads to not only uveitis but also leads to lens capsule ruptures. Lens capsule ruptures result in intense uveitis, which can lead to retinal detachments and glaucoma. One should not wait on performing surgery on diabetic cataracts. Topical anti-inflammatory treatment with diclofenac or flurbiprofen should be utilized once to twice daily. Ulcerative keratitis can also lead to secondary uveitis. Corneal ulceration can lead to a reflex uveitis. It is important to not only manage the ulcer, but also the uveitis. Atropine helps these patients quite a bit and can be dosed at once or twice daily. In this patient, consider topical antibiotics such as ofloxacin and terramycin, topical anti-inflammatories such as diclofenac, oral anti-inflammatories such as carprofen, and topical atropine. Do not use topical steroids with corneal ulceration under any circumstances. Neoplasia within the eye is a common cause of secondary uveitis in patients. Tumors can be primary intraocular tumors or secondary as distant metastasis. Primary intraocular tumors generate very low-grade uveitis that is not typically witnessed by the client or the veterinarian. Secondary tumors typically create intense inflammation and secondary glaucoma that is able to be seen by the client and the veterinarian. So if you look at these two photos, the first one shows a secondary tumor that has metastasized to the eye, creating intense damage, whereas the second photo shows a primary intraocular tumor which creates low-grade uveitis. Fungal causes are common with secondary uveitis: blastomycosis, aspergillosis, histoplasmosis, and coccidiomycosis. In many cases, the eye is the only clinical abnormality. The patient may not be sick just yet. It's important to obtain an etiologic diagnosis in order to not only treat the eye appropriately, but also to potentially save the patient's life. In cats, non-infectious causes include autoimmune, which is the most common, or neoplasia, with the most common being lymphoma. Ulcerative keratitis can also cause uveitis as well as trauma. Infectious causes include viral, such as feline leukemia virus, feline immunodeficiency virus, and feline infectious peritonitis. Fungal causes such as cryptococcus, histoplasmosis, and aspergillosis, and toxoplasmosis. Primary feline neoplasia causing uveitis includes uveal melanomas, uveal adenoma or adenocarcinoma, post-traumatic sarcomas, or solitary ocular lymphomas. Secondary tumors or metastatic tumors include lymphoma, adenocarcinoma, and fibrosarcoma, amongst others. There's questions to ask yourself following your diagnosis. Is this a primary or secondary uveitis? Is there a corneal ulcer, a cataract? Is there a mass in the eye? Is my patient systemically ill? Is there vomiting, diarrhea, coughing, etc.? Are lymph nodes enlarged? Lymphoma is a very common cause of uveitis. Make sure to check your lymph nodes. Check mucous membranes, petechia, jaundice, depigmentation, etc. Assuming that you've ruled out trauma and ulcerative keratitis in your canine patient, how are we going to work these cases up? First and foremost, let's do a physical examination. This will help direct and prioritize your testing. Next would be routine lab work: complete blood count, serum biochemistry, and urinalysis. Next, we're going to look at disease-specific testing, such as a SNAP-4Dx, which includes tick titers, fungal urine and serology, and lymph node aspirates. Next would be imaging, such as X-rays and ultrasound of the abdomen. Next would be biopsy of any lesions that you may find on the body. Further down the list would be aquiocentesis or a vitreocentesis, which are rarely performed. And lastly would be enucleation, removal of the eye with biopsy. With cats, it's very similar. We're going to start with a physical examination to help direct and prioritize testing. We're going to run routine labs such as complete blood count, serum biochemistry, and urinalysis. Disease-specific testing including feline leukemia virus, feline immunodeficiency virus, coronavirus titer, toxoplasmosis titer, and fungal serology. Imaging can include chest X-rays and abdominal ultrasound. biopsy of any lesions that you may find, aqueocentesis, vitreocentesis, and finally a nucleation with biopsy. So where do we start therapy? Therapy, we start topically as it's the first line for the anterior segment. Corticosteroids, only if corneal fluorescein stain is negative. We're going to dose that every 6 to 8 hours and then taper it over time based on response. Non-steroidal is generally safe with corneal ulceration, and that's also every 6 to 8 hours, and then we taper it over time based on response. You can use Mydriatics such as atropine every 8 to 12 hours, but taper this one quickly. Do not use atropine if the intraocular pressure is high or high normal. Do not use atropine if there is concurrent keratoconjunctivitis sicca. And use atropine ointment in cats so that the atropine liquid does not go down their nasolacrimal duct because it's bitter and it will really aggravate the cat. For systemic treatments, use if posterior segment involvement or if topical alone is ineffective. Corticosteroids, it's important to rule out systemic mycosis first before prescribing corticosteroids. Dose and taper is cause and disease dependent. Non-steroidal anti-inflammatories can be used such as carprofen and meloxicam. Analgesia includes NSAIDs and tramadol, which are quite effective. Antimicrobials are disease dependent, and immunosuppressants may be required in autoimmune cases. It's important to manage the underlying concurrent disease, ulcerative keratitis or a cataract and glaucoma, etc., etc. Make sure you're keeping the entire picture in front of you. Continued management, we're going to recheck early in the beginning. We're going to recheck them in about 1 week after their initial consult, then 2 weeks after that, maximum for initial recheck. Irreversible intraocular changes can happen very quickly. There's a high likelihood of glaucoma if the inflammation persists. Initially, this is a guarded prognosis. There's no underlying cause that has been determined yet, state of the eye at presentation, response to treatment. Often this is a chronic disease. You need to educate clients that it's a chronic disease. There are going to be periodic rechecks and medication adjustments are likely. Some take-home points include uveitis is a non-specific diagnosis. What's driving the inflammation? We need to do a complete ophthalmic examination. Find the aqueous flare. Be careful of diagnostic pitfalls. Perform thorough physical examinations, as these are essential. Testing should always be offered to the client and encouraged in order to find a definitive cause. Don't go light on topical anti-inflammatories, as we want to get the inflammation under control quickly. We're going to recheck these cases early, and referral in severe cases can be beneficial. If you feel like you are overwhelmed with these cases, you shouldn't be embarrassed or ashamed of referring a case. That is what's in the best interest of the patient. If you feel like you do not know how to approach a case, then those should be referred as well.